And before we go on, I'd like to acknowledge the greatest honor we have today, the true greatest honor. The founding father of modern cardiology, Dr. Eugene Braunwald, had joined us, Dr. Bogie. I would like to invite Dr. Braunwald, if he wishes, to make a few comments. We are most honored. This is the greatest honor for JCA and all of us in cardiovascular field to benefit from Dr. Braunwald's visionary leadership over the years.
Well, can you hear me?
Yes, sir.
Yes, yes.
Okay. Well, it was an honor to hear you, Roberto. I think
thank
that it's a magnificent lecture, and I think this should be used as an example of how to take a very complex issue and move it forward. I also want to congratulate you on the more recent trials that you showed. And I just have one question. You've demonstrated unequivocally and logically that one injection is not going to do the trick. And yet the last 3 trials, as I understand what you just said, they only received 1 dose. Is that correct?
Yes, yes.
And wouldn't it be better to have gone like every 3 months or every 6 months?
Yes. First of all, thank you, Dr. Braunwald, for your comments, which really they mean to me more than I can say. It's an incredible honor to have you listen to this lecture and to be able to discuss this with you. You're absolutely right. So all the trials have shown use only as 1 dose of cells, and the reason is that the cells were delivered by the transendocardial route, which basically only allows you 1 shot. It's almost impossible to do repeated injections by the transendocardial route. Patients.
Why?
Because it requires invasive cardiac cath and patients' adherence. It's difficult to convince patients to undergo repeated procedures. It's expensive and it's complex. So it has not been done so far in clinical trials, and there are also risks associated with the transendocardial injection, which we must also keep in mind. It's not really a totally safe procedure. But the issue of repeated doses, I think, can be addressed with intravenous administration. That is something that I mentioned briefly at the end. One of the greatest advantages of intravenous delivery is that you can do it as many times as you want. You can do it as an outpatient in a clinic. You can do it in rural hospitals, in theory. And we are actually doing a trial now, that I'm starting, the keto trial, where we are delivering umbilical cord MSCs by the intravenous route to patients with ischemic cardiomyopathy, and we are comparing 4 injections with 1 injection or placebo. So if that intravenous delivery proves effective, that would be a game changer. It would really transform cell therapy dramatically, because it would allow, first of all, a lot of patients to receive cell therapy which otherwise could not because of the costs and complexities of transendocardial delivery, but secondly, repeated dosages. And so it would be...
Well, so that there's hope.
Yes. We are starting
because
now.
You haven't you haven't given it the ultimate test, because the ultimate test the results are very encouraging, but I think it could take you over the top if you could do some intravenous infusions and show that the benefit is continued and enhanced.
Yes, yes, and it's actually amazing that a single dose has been able to produce some signal for efficacy, despite just being a single dose. So we are looking forward to this trial. One may ask why in the world would intravenous therapy work? Because cells will not reach the heart. But we now know that in chronic heart failure there is a systemic inflammation. And this systemic inflammation may drive the progression of the disease. And intravenous MSCs, mesenchymal stromal cells, they do attenuate systemic inflammation. This has been shown in many other diseases, Crohn's disease, ulcerative colitis, graft versus host disease, in amyotrophic lateral sclerosis, and on and on and on. So in other areas of medicine, the MSCs have been already used to treat systemic inflammation. So we are hopeful that they will also be beneficial in heart failure.
Thank you. Thank you very much.
Thank you very much, Dr. Bond.
Thank you, Dr. Braunwald. We are most grateful to you, sir. There is, let's see, from panelists, if not, I have one question from the audience. JJ, which means Jack Joels, would like to know which variables should we use to determine the optimal number of MSCs in clinical trials?
Which variables to determine the optimal number of MSCs. So as far as the transendocardial injection, I think Josh Scher actually did studies in this particular topic. We are limited by the number of cells that you can possibly deliver with each injection, right? So an injection volume greater than 0.3 milliliters is associated with some problems. And we try to keep the volume at 0.2 to 0.3 milliliter per injection. And in 0.2 or 0.3 milliliter of solution, the number of MSCs that can be squeezed is finite. So we have been using 100 total number of 150 million MSCs in concert. Most other people have used similar numbers, 100 to 150. So practically speaking, you cannot give more than 150 to 200 million MSCs in a patient because of the constraints of having the cells in suspension and the amount of volume that you can inject in the heart. Now, intravenously is a different story. Intravenously, probably the number can be much higher, and we still don't know. We can only go by what has been done in other disciplines of medicine, like oncology, hematology, or gastroenterology, where they use usually 200, basically 100 to 200 million per injection of MSCs.
I have one question from panelist Professor Raffaella Lombardi, and also one question from the audience, Dr. Tamir Mohammed. Dr. Lombardi, you first.
Yeah.
Oh, sorry, I heard Dr. Braunwald said something. Okay, you are Dr. Lombardi.
Yeah, so maybe my question is a little bit provocative. So, because, I mean, as it's established now that these cells have a paracrine role more than really a direct role, and everything seems to point toward the inflammation, the anti-inflammatory effects. So what is the advantage of using the whole cells instead than, for example, develop an anti-inflammatory drug or try to isolate the extracellular vesicles from these culture cells and then inject to the patients?
Yeah, so that's a great question, Rafael. Thank you. The advantage is that MSCs produce a panoply of anti-inflammatory factors. As I pointed out, we are talking about tens or maybe hundreds of chemokines, cytokines, microRNAs, long non-coding RNAs, extracellular vesicles, lipids, and on and on and on. So they affect the immune system at multiple points simultaneously. And in my opinion, that is probably going to be a better anti-inflammatory treatment than just giving one drug that affects one cytokines or one receptor or one signaling pathways. As you know, the immune system is infinitely complex, and the MSCs have this ability to tackle it at several different levels.
All right. Two questions for you from the doctor. One is from one of your former colleague, Dr. Tamer Mohammed. Great talk and very inspiring. If we are going intravenous, could it be done by continuous perfusion for a week to maintain the cells in circulation longer in one go to have a better effect than the space dosages?
Thank you, Tamer. So that is an interesting thought. It would be like a continuous release insulin pump rather than giving a bolus of insulin. I don't know. I mean, theoretically, it's possible that you could have a reservoir of cells and device, a pump that infuses them continuously. That's an idea, Tamer, to pursue. But I think first we should see whether bolus injections every 2 months or 3 months or whatever are efficacious. And then look at the continuous infusion, because also the continuous infusion, I presume, would require an enormous number of cells. I'm not quite sure how that could be stored, in a container or in a pump. Or anyway, it's an interesting thought, certainly to be kept in mind.
Dr. Bowley, one anonymous attendee would like to know your opinion about epicardial patch, delivery of the cells through epicardial patch.
Yeah, so that is also has been used by some investigators. The main limitation I see is the invasive nature, right, of the procedure, which requires, I believe, opening the chest and applying the patch on the surface of the heart. So that could be done during bypass surgery, maybe, or other surgeries. But in terms of a widespread treatment or a widespread modality of delivery, I believe it would be not really very practicable.
All right. One final question. What is more cells, if you inject more cells, is it better for a paracrine effect? This is from, again, Jap Jules or Yules.
I think so. In theory, more cells means more paracrine factors. So I believe so. But we really, there are so many unanswered questions in this field. We really don't have a good dose response study with cell therapy. There have been a few comparing 2 dosages, but not really something that I can put my confidence in, so to speak. So the dose response is still something that I believe needs to be worked out.
Excellent. So I see that 2 more hands went up. These are the final questions. Dr. Gerha and Dr. Philip Yang. So let's go with Gerha and then Dr. Yang, and that will be conclusion of today's webinar.
Thank you very much. That was a very lucid and very clear presentation and an enormous amount of work there, Dr. Bowley. So my question is that you see an effect which can extend up to an year. To me, it does look like there may be some epigenetic changes that these inflammatory or anti-inflammatory secretions are doing. Mechanistically, have you looked into mouse models or other models to see if there is any epigenetic reprogramming, and that may explain the long-term beneficial effects?
Now, that's a great question. I agree with you. To me, one of the things that has always puzzled me is why is it that we give cells, we know these cells disappear within months or 2 months, and yet we continue to see an improvement in function even when the cells are gone. And I think you're right. My hypothesis is that cells somehow reprogram the myocardium or certain components of the myocardium so that cardiac function will be improved. And that could be an epigenetic reprogramming. You're right. No, I have not studied that. I wish I had someone who could study it with me because I am not an expert in epigenetics. And I would love to collaborate with anyone who is interested. But it's certainly a very, very intriguing hypothesis.
Phil.
Right.
Thank
So,
you, Philip.
thank you, Roberto. That was a wonderful talk, and as always, a real pleasure to listen to you.
Thank you.
Certainly
Thank
worth
you.
waking up at 6 in the morning in California time.
Are you awake or are you still asleep?
No, I'm awake. That's why I'm asking you a question. So I think the discussion was wonderful. I think, we talked about the cell type, we talked about the dosage, we talked about different type of delivery method and mechanism of action and so forth. I just want to touch upon one comment that you made, which is there are many questions that need to be answered in this field, and I completely agree with you. What do you think, given the current environment, funding, confidence, patient reaction to what we're doing, where do you think we need to go from here to really regain some of the confidence that was lost by patients, by our colleagues, and so forth? How can we go up the curve that you showed us at the beginning of the talk? I don't want us to plateau at this point, but I think we still need to kind of ascend and try to bring back this whole concept of cell therapy in daily practice of cardiology. What is one thing that you think is necessary for us?
Yeah, thank you, Phil. That's a great question. And you're right. There is, unfortunately, a tremendous amount of negativism and nihilism and pessimism on cell therapy. And we are all aware of that. And at the moment, there are very few ongoing trials of cell therapy in patients with heart disease, which is really a shame. I'm not sure, Phil, how this situation will get better. I think the only way to change this perception and to reignite or rekindle interest in cell therapy research is by having data that show solid data, rigorous data that show beneficial effects. But then, of course, in order to have those data, you must have clinical trials. So it is like a catch-22, because if you don't have trials, you cannot show good data, and if you don't have good data, you cannot have trials. It is a difficult situation, Phil. I think DREAM-HF has helped, because even though it was a negative study, technically the primary endpoint was not met, it did show that remarkable reduction in MACE, in major adverse events, which was a secondary endpoint. And this was a double-blind randomized study. So it is high quality work. And I believe that the company Mesoblast is planning a follow-up study in patients with high hs-CRP, in inflamed patients, where the mesenchymal cells are most likely to be efficacious. So that trial could certainly change the field, but that's going to take several years. I believe the editorial by Dr. Brownwood last year was also very important. I think that made many people rethink about their prejudice against cell therapy. And I think all of us have to continue to do, to send a message to the NIH that's the main body, of course, in this country, that cell therapy is a promising, which must continue to write. I've done it as much as I could, but all of us should write reviews, editorials, pointing out these promising results of clinical trials that, in my opinion, provide a rational reason for moving forward and testing this therapy in a more definitive manner. It is very difficult, Phil, as you know, and I'm not sure I answered your question, but I agree with you entirely that it would be a shame to abandon this treatment because of things that happened in the past, and that we should try to conclusively test the efficacy of cell therapy.
May I
Dr.
add
Bowley.
one-
Oh,
may I
Dr.
add
Tagmeyer.
one brief point. I'm sorry we are over time, but Roberto, this was beautifully lucid and really a joy.
Thank you.
to listen
Thank
to.
you.
There is hope. Consider metabolism and metabolic flexibility. The distinctly different metabolic pattern of embryonic and fetal cardiomyocytes or cells in general. And then the transition to the adult form of cardiac metabolism, both on its catabolic arms, but also in its anabolic arms. And I think that is a largely unexplored area. Might explain, I mean, that's a speculation, between the autologous and the allogenic stem cells.
Yeah. So we were talking earlier about reprogramming of the myocardium. And I think the cells, actually, one of the things they do, they probably reprogram the metabolism of the myocardium. I don't have any data to prove it, but it just makes sense. If you see a long-term effect after a single dosage, there will be some kind of metabolic reprogramming of the heart. And again, I'm not a metabolic expert. I would love to be able to collaborate with someone to look specifically at this particular aspect of cell therapy.
It is a hypothesis that can be tested. Yeah, thank you.